Hello, the topic of today is obesity. My name is Stephanie. This slide I prepare and the talk to really kind of think about how we deal with the patient in the office and to give you some tip. And there has been so much new stuff in the last couple of years. We have new medication, we have new guideline, so I try to include a little bit of that to make you aware. I put a lot of information in the slide and we are able to cover, but I thought at least you would have the reference, and then if you're interested can dig a little deeper on your own. So you probably all know the definition of obesity. The body mass index above 30, and so many health risks are associated with increasing BMI. The overweight range when BMI between 25 to 29.9. We say obesity when BMI above 30. There are three classes of obesity, and the class 3 is BMI above 40. And without going into too much detail, you can see from the physician health study data, BMI of kind of 25 to 30, the overweight range, they increase the risk of disease like hypertension and coronary artery disease is increased. What's really profound is the link between obesity and the type 2 diabetes, and I think the data just so powerful. I want to highlight it. A woman with a BMI of 35 has a 94th risk of developing diabetes compared to a woman with a BMI the 22 range. Let me explain the term a little bit. This is hypertension, coronary artery disease, and this is type 2 diabetes mellitus. And we know a lot about mortality, and BMI and increase the mortality, increase the BMI of 22 to 23. But I think what's kind of more important is for us to focus on knowing that health risks associated with obesity, and can we tell our patient that there are benefits of the weight loss. And again, the stronger list, this link is with diabetes, and I tell my patient this all the time from the diabetes prevention program. We learned that the patient who were randomized to an intervention of dietary modification and exercise who lose importantly of 6.7% of their starting weight in that intervention at a 58% reduction in the development of diabetes. So huge reduction. And this is better than the arm that got randomized to metformin, which also had a significant reduction of 31%. In conclusion, the patients who were randomized to intervention of dietary modification exercise who lost importantly of 6.7 of their starting weight in the intervention at a 58% reduction in the development of diabetes. So huge reduction, and this is better than the group that got randomized to metformin, which also had a significant reduction of 31% but not so robust. So losing weight and doing more exercise, even modest weight loss, has a profound impact on the risk of developing diabetes. And analyze a different way, the people who lost more weight were able to reduce her risk even further. So let's turn to evaluating the obese patient in our office. And I cannot emphasize too strongly enough as prevalent as it is, and this is the one disease that probably everybody knows something about because it's on the news. Even people not in the medical field, obesity really is undiagnosed and undermanaged. There's a study from the Mayo Clinic and many like it where they took 2,500 patients who had gone into a visit with their primary care doctors who had a BMI above 30, and the diagnosis of obesity was only put into their chart 25% of the time. And what you can see in the black bar is that those when obesity, what the BMI was written in the obesity was put on the problem list had an increased counseling rate. So being aware of it, putting it on the problem list, documenting the BMI help us to trigger us to consult our patient about it. And how are we going to counseling the patient? This is the part that I edit in this slide because I think it's so important and it's so difficult to broach the subject with our patient. And so I just wanted to give you some idea about what I do and what other psychologists and other people who are, expert in the care of patients with obesity are saying so. There is a sentence I want to highlight, such an important piece of this. We have the opportunity to treat the patient with respect. This is in the counseling of obesity. Such as experience may be the greatest gift that a doctor can give an obese patient. There's so much stigma with obesity. These patients feel like they are judged and they are not treated with respect. And so when the counseling can be done with sensitivity, it can be very empowering to the patient. And so some of things that we talk about when we talk to patient to really kind of take away all of the blame that associated with this disease is to say that obesity is a disease, and 2013 it is officially become the disease. We understand more that they are biological factor, that they are environmental factor, and they are social and psychological factor. It is complex. It's not just about it's your fault to eat too much, and it's kind of advocated that we do talk about biological predisposition that they may have. And this sentence I put in the slide: you appear to have a predisposition toward a weight problem, just as some people are born to be tall. You appear to have a predisposition toward a weight problem, just as some people are born to be tall. Weight trait run in the families. This may explain why you have a struggle with your weight more than most people. Something along this line in your own word can be so validating to a person and feel like you understand them in a way that perhaps other medical providers have not understood them before, and feel more comfortable engaged to make a change. There have been studies about what term patients prefer that we use when we address or wait for them. This is excellent study from Walden et al. And the preferred term is overweight, not excess weight, not fat but weight. And some of things that they talk about in this article about initiating the conversation using this terminology. All things like your weight has increasing by 10 pounds, very matter of fact. But do you make of that open it up to them? We have not discussed your weight recently. What are you talk about your weight in the health at this time? Try to understand where is the patient at this time. Is this a good time for them for an intervention? And we have to assess how ready they are to lose weight. Similarly to how we assess smoking readiness to quit. How prepared are you to make a change in your diet, to be more physically active, and to use behavioral change strategies such as recording your weight and your food intake? And this is going to be a very good way to open a conversation to understand if this is a good time and there is such psychological preparedness and barrier are not. And if the patient is not ready now, then continue to have this discussion at the visit may help them to kind of persist along them continuum of readiness for change. And our thinking has really involved in the term of how we help people to make behavioral change, and the use of motivational interviewing technique even in the primary care practice really seem to have enhanced of efficacy and make the patient feel like they are in control. So we really want to encourage our patient to come up with their own personal reason for change. And I do tell the staff about diabetes. For example, some of the patient, part of their motivation is because one of their parents is diabetes and they don't want that. So some of that data that I saw up front can be empowering to them. But more important than anything is our reinforcement of their decision to change, to really help them to prioritize that behavioral change opportunities and identify what they is like exactly. But more important than anything is our reinforcement of their decision to change, to really help them. But more important than anything is our reinforcement of their decision to change, to really help to prioritize the behavioral change opportunity and identify what they is exactly. If the patient is not ready now, then continue to have this discussion at visit may help them to kind of process along the continuum of readiness for change. And I think has really involved in this term how we help people to make behavioral change. And The use of motivational interviewing technique, even in the primary care practice, really seem to help enhance of efficacy and make the patient feel like if they are in control. So we really want to encourage our patient to come up with their own personal reason for change. But more important than anything is our reinforcement of their decision to change, to really help them prioritize behavioral change opportunity and identify what are some of things that they can change and what are some of the barriers that they are feeling toward making those changes. Encourage them to identify social support and to make commitment to a small step. And we are going to make a small step incrementally, and they don't have to start by exercising every day. That's probably not realistic, but they can commit if that's a goal that comes from them. That's probably not realistic, but can they commit? That's probably not realistic, but can they commit if that's a goal that comes forth from them, that they want to move more? Can they commit to 20-minute walk once a week and then build on that? So kind of this bunch of layering so that they can get to the point where they have made significant change and been successful. But again, kind of working with them to understand where they are and their reason for wanting to make change, and then helping them to kind of from that really critical to help them have a realistic goal and expectation. And some of the data that I show you now kind have the amount of weight that realistic for the patient to lose weight. So we can expect that the patient will lose 5 to 10% of their weight if they are successful. This slide is about the goal that is realistic. So 10% in 6 months they can lose their weight, or 5 to 10% in 6 months they can lose their weight. Many patients want to lose much more weight than that, and so kind of helping them to guide the realistic expectation is important upfront. We can expect that patient will lose 5 to 10% of their weight if they are successful, and many patients want to lose much more weight than that. So kind of helping them to guide the realistic expectation is important upfront. So the old document recommend 10% weight loss in 6 months, and the most recent guideline, when I'm going to tell you a little bit about in the next few slides. Now we can expect that the patient will lose 5 to 10% of their weight, and we want to focus on health goal. Can we help reduce stress? Can we help healthy sleep? Can we help reduce hemoglobin A1C? That kind of focus on health is probably important, more important than focusing on the weight number. But since we do have so many patients who present with very unrealistic expectation about what they can manage to lose in 6 months, even if they try really hard. So this kind of goal setting and expectation reminder some upfront is helpful. So finally, in 2013, all of these different groups who have expert about the management of obesity got together and developed these guidelines. They are not perfect, but they are certainly way overdue, and I recommend this as a reading to everybody, even in the primary care setting, because really it's very interesting reading, and they kind of develop guideline, ask question how they review the evidence. So I'm going to try highlight a few points that they are made. I already give the link so you can check it. In this link, if you open, they do have this algorithm about how to treat patients with diabetes, way too complex for me to go through every step with you. And it basically has to do with kind of at what weight BMI cut off to revert to what different types of program, when to consider the pharmacotherapy, when to consider surgery, and we'll go through the different bit of it in the next part of the talk. This is the link, you can check by yourself. It basically has to do with kind of at what weight BMI cut off to revert to what different types of the program, when to consider a pharmacotherapy, when to consider surgery, and we'll go through the different bit of it in the next part of the talk. You can see and read by yourself. The bottom line of the therapeutic tool that we can use to treat our patient is still remain diet, behavioral modification, physical activity, medication, and surgery. The bottom line of therapeutic tool that we can use to treat our patient is still remain diet, behavioral modification, physical activity, medication, and surgery. So want to talk a little bit about each of these. There's so much written about diet, Atkins and low fat, and you name it, there is a diet program out there. And so one of the questions that we get so often is calorie really a calorie, and is there a way to cheat the system so I can eat a ton and lose weight? And everybody wants to know, but the data really suggests when we are able to randomize patients and put them into different dietary prescription. This is a study from Harvard School of Public Health. First group got a high protein diet. Second group got bulk a low fat diet. There were different amount of carbs, and basically all the patients in the different group did about the same. They lose about 7% of their weight at 6 months. They had regained a little bit after 2 years, but had kept some of it off. And it didn't matter what macronutrient composition group they got randomized to, they all did about the same. I think that the science is evolving on this, and we already know that we were able to understand that for certain group of patients certain types of diets are better. How do we understand that? Are there certain genetic makeup that come from specific response to a specific diet phenotypic? How do we understand that? Are there certain genetic makeup that conform a specific response to a specific diet phenotypically, etc. But what we know today is that really in order to lose weight we need to restrict calorie, and we cannot cheat the system by different macro composition percentage. And along with this 2030 guideline recommend that you prescribe the following: 1200 until 1500 calorie a day for women, 1500 to 1800 calorie a day for men. There may need to be some adjustment for that for people with severe obesity, and this is about 500 to 750 calorie per day. Energy deficit, so they're net negative in this range, and they basically say that you can recommend any of the diet that have some evidence behind them. Energy deficit, so they're not negative in this range, and they basically say that you can recommend any of the diet that have some evidence behind them. So anything that has had some published study that show there is some weight reduction, so high carbs, low carbs, high fat food in order to create calorie goal to meet the calorie goal. And then the question is, how do we help people stick to those goals? Because it is very difficult, and so some of evidence-based strategy that come out repeatedly that study try to help people to lose weight are kind of the following the behavioral techniques. So using caloric and portion food, and I talk about meal replacement in the study where people adhere to meal replacement. They do lose significantly more weight, and this can be frozen milk, liquid milk, frozen bar. The idea that there is fixed portion of that they are going to eat. They are not going to eat more rice on the plate track of it. They are convenient. They are generally inexpensive as a part of a sensible plain menu, and you may be able to recommend this to your patient. So maybe they can replace lunch with frozen milk. A frozen meal. We do sometimes use a shake program, but I think that has to be medically supervised. The other thing that comes as a kind of behavior strategy to help support people sticking to their limited calorie diet is frequently follow-up visit. It does not have to be with physician. It can be another person in the practice who kind of affiliate with the practice, but clearly the number of sessions that people attend, that accountability, that connection with the support seem to be very important for successful weight loss. And the final thing is self-monitoring. If your patient want to lose weight, you should encourage them to keep a log. Write down everything they eat and how much they exercise, and track their weight, and that accountability to themselves, and really seeing and keep track of their behavior is what's going to win, and being aware, so it's going to enable them to make behavioral change. And finally, if you have time for nothing else for them, to a commercial weight loss program, because when people are randomized to standard care in a primary care office setting or just being told to go Weight Watcher, they do better at the end of 1 year. when they had gone to a commercial program. Exercise really critical important, because even if they don't lose any weight, this is what I tell to my patient. Fitness is an independent predictor of mortality for the same BMI. So although exercise alone has limited effect on weight loss from a lot of study, and patient will tell you, I started exercise, I did not lose a pound, I'm so discouraged. Adding exercise to calorie restrict diet does enhance the amount of weight we lose. And very important, exercise seems to be critical for the long-term maintenance of weight loss, which is really what we want to do. We don't want them to lose weight and regain again. We want them to lose and keep it off, and exercise a critical part of that. I do encourage people to use pedometry because a very good meta-analysis now support this, and patient who use pedometry and who importantly set a step goal were able to increase their activity, were able to lose some weight, and patients who use pedometry and who importantly set a step goal were able to increase their activity, were able to lose some weight, and it had an effect on systolic blood pressure. So this would be very concrete recommendation you could make to your patient. The systolic blood pressure decreased by 3.8. So I want to cover the topic of medication and surgery. So weight loss medication. The indication are BMI above 30 and a BMI above 27 with comorbidities. The medical doctor must strict about this. I do get patients with BMI of 24 who gain 20 pounds and really want a pill. And I think it's very important for us as the medical community to really treat people who have obesity as a disease with medical comorbidities and use them in that regard, because these are medications that have side effects and potential complications. I will go over them with you. But we have also come a really long way, and just as we have pills to treat other medical conditions, we now have a limited set of pills that we can use to help the right patient with obesity. It should really be seen as adjunct to diet and exercise. They really have to do either already engaged in calorie restrictions, either they really have to be either already engaged in caloric restriction and exercise, or if you are going to start medication, help them find a place where they can exercise, or if you're going to start a medication, help them find a place where they can engage in that. I don't think it's appropriate to just prescribe the pill and do nothing else, because really when we look at all the patients in the study, the medication work, but those patients were engaged in a diet and exercise program as well. But those patients were engaged in the diet but those patients were engaged in a diet and exercise program as well. When the diet and exercise alone has not successful, maybe opportunity to think about weight loss medication. This is the medication list for the obese patient. We see that all the medication, and I think I have a different side effect about this, there is heterogeneity of response. So to each particular medication, one person might have a very good response and another person may have no response at all. And that doesn't mean they won't respond to other medication, but there seem to be really, you need to be fit between the sort of person chemistry, the underlying of biology of their disease, and what the medicate have the medication works. And so because of that, we really want to think about, is this medication working? And we have some guideline. So if they don't lose 5% of their weight in 3 to 6 months, with some, there's opportunity to adjust the dose and see if that works. But if not, we really want to discontinue medication because we don't want to be exposing patient to the potential side effect if they don't work. And we know that some people are not responder, so we have an explanation for why it's not working, and maybe try to stop that medication and try something else. But the corollary of that is that this medication should probably be thought of more similar to how you think about blood pressure medication. You know that you prescribe an antihypertensive and it works to lower blood pressure, but if they go on vacation and leave the pill at home, stop taking them, their blood pressure is going to high again. So this medication, anti-obesity medication, similarly work while they are taking. They don't cure an underlying disease. So if the medication works for person and the person lose weight, we probably need to think about continuing as a long-term thing in order to maintain the weight loss effect. Because what we see from the study, that the study from now for approval, the FDI need to be 2 years, so that they have a long-term indication of proof. Basically, if the patient who kind of at the end of the 1 year get randomized to placebo, they regain most of their weight back. So these are things I think important for the patient to understand upfront. The medication that approved for obesity are pentramine, which is a generic, has been on the market for a long time, and about 5% of weight loss can have, which is a generic and has been on the market for a long time, about 5% weight loss can have increase in the heart rate and blood pressure. Those need to be monitored. It is generic, so it's cheap. There's been great excitement approved in 2012, a combination of pentramine and topiramate. It's marketed as Kismia. It has the most robust effect on the weight loss, about 7 to 9% on average, and it has unfortunately topped the side effect of pentramine and topiramate, so they have to be monitored. You start a 2-week low dose and then you bump up to this sort of medium dose, and there's opportunity for a higher dose. If there is some weight loss response but not sufficient, topiramate is teratogen. Topiramate is a teratogen in a woman of childbearing age. Topiramate is a teratogen in a woman of childbearing age. You have to monitor this, and it should not be given to patients who had cardiovascular disease in the last 6 months. And I'm actually fair conservative. I don't use pentramine in patients who had significant coronary artery disease. The other medication that's on the market is lorcaserin, marketed as Belvic, a more modest weight loss above placebo 3.5%. Beware that it can worsen headache. It doses 10 mg TID, and it probably really should not be used concomitantly with SSRI. Lorcaserin should not be used together with SSRI, which many of our patients are on, because there is a risk of serotonin syndrome. And then the kind of older medication that's marketed that I almost, and there is another medication is orlistat lipase inhibitor, which has about 3% weight loss above placebo, but significant side effect of steatorrhea, which is very uncomfortable for patients. This is I explained before. Some patients respond to other medications, some not, but it doesn't mean that they don't respond to other medications, so you can try to another medication of weight loss. But weight loss medication works similarly like antihypertensive medication. If a patient take antihypertensive medication and then they go to vacation, the blood pressure is high again. So weight loss medication is not treat underlying disease. So off-label, we use a lot of medication off-label, and some of them are being marketed in the process of being approved for this indication for the FDI. But topiramate 25 mg PO/BID to relative low dose. Sometimes I use infrequently in the patient for this indication, and really more to see if they have an appetite suppressant response. Okay, so finally, bariatric surgery. So everybody should be familiar with the indication for the surgery, because patients are more and more bringing this forward on their own. Basically, 3 options: the lap band, the Roux gastric bypass, and the sleeve gastrectomy, which is kind of come on the scene as the newest player. But it is on the up and up. Many more sleeve gastrectomy are being done, many more fewer lap band, or many fewer lap band are being done, and that's a global trend. So if the body mass index of 35, so if the patient has comorbidity of their weight, hypertension, diabetes, etc., then they can qualify of a body mass index of 35. If there are no comorbidity and the BMI has to be 40. This is the mostly an insurance payment issue. There's a lot of research being done on whether the surgery should be thought of more as a metabolic surgery for the treatment of the complication, not just the weight. and the cutoff should be allowed to be lower. But this is the current who currently stands, so kind of the comparison of this surgery. You clearly lost the least weight with the lap band. With the sleeve is about 50 to 60% of excess body weight loss, and with the ruin is more like 60 to 70% weight loss. The ruin is probably the most complicated of surgery as far as the surgical time and the complexity, and because of that many surgeons will steer patients who had coronary artery disease or just more complex toward the sleeve. You spend less time in the hospital if you get banned, and the risk of death is the lowest with the ban. So many people kind of piss off. They talk of it as the safest surgery, but the problem is that although there may be fewer very significant complications, there are a lot of minor complications. But patient discomfort, the band sleep, and the band of the man even need to be taken out, and when you add all those together, it's not insignificant amount, but probably for this reason it's being less and less favored. It is medically reversible. That is something that patients also focus on, but because the sleep is not something that is reversible, they actually take out part of stomach in ruin, they leave it in the body, so there's potential for reversible. That is excluded in the ruin why they live in the body, so there's a potential for reversal, so that be needed. But obviously that's very complex operation, and they all have some rate of complication, but it's remarkably safe surgery, and has the surgical number have been improving a lot as more and more surgery are done. So let me show you some of the facts. This is a 10-year data. We now also have a 20-year data from the Swedish obesity study. This is not randomized but case control, but you can see that even after 10 years of follow-up, the rate of people keeping the weight off is really remarkable. It's really good, and we had a very interesting result from some randomized control trial that when you randomize patients who have diabetes to surgery or to a lifestyle intervention and diabetes treatment program, the patient who have diabetes do remarkably well after this operation, with somewhere between, depending on how you define it, somewhere between 40 to 80%, and then them going into remission at the 1 year to 2 year and time point. So when I have patient have diabetes who are interested in surgery, I'm definitely counseling them one more toward away from the lap band, and she's not metabolic surgery, and more toward this sleeve, ROIN, and even the 3-year data looks like improvement in diabetes. And so let me show you some of the facts. This is a 10-year data. We now also have 20-year data from the Swedish obesity study. This is not randomized but case control. You can see that even after 10 years of follow-up, the rate of people keeping off the weight off, it's really remarkable. It's really good, and we had a very interesting result from some randomized control trial, including our own that came out just a few weeks ago, that when you randomize patients who have diabetes to surgery or to a lifestyle intervention and diabetes treatment program, the patient who have diabetes do remarkably well after this operation, with somewhere between, depending on you are define it, somewhere between 40 and 80% of them going into remission at 1 to 2 years time point. So when I have a patient who have diabetes who are interested in surgery, I'm definitely counseling them one more toward away from the lap band, and she's not a metabolic surgery, and more toward this sleeve or when, and even the 3-year data looks like improvement in diabetes. All those not as sustain us at 1 year data, it's still much better at the 3-year time point. I did want to just mention quickly, I think that the follow-up of bariatric surgery patient is coming more and more into the realm of primary care doctor. The bariatric surgery is the whole process, and beforehand they see the surgeon and they go to the group. They have to have a psychiatric clearance, a sleep medicine consultation, and in the post-operative period immediately, the surgeon in the team may be more involved in taking care of manage the diabetes and to hypertensive. But I think it's very important for all of us to be aware of this thing, because many times they do need fewer antihypertensive and diabetes medication and things like that. That is for safety. We want to be sure we are on the tops of things. Importantly, they really need like lifelong follow-up. So micronutrient monitoring, micronutrient supplementation, by indeed to multivitamin a day, all are things that we need to be aware that our patient need upon follow-up bariatric surgery, especially after the sleep and ruin gastric bypass. That's whole different talk. But for you who are interested, then there are guidelines about post-surgical management of bariatric surgery that outline exactly which tests that should be doing, what frequency, and what should prescribing in terms of supplementation. So in summary, obesity is defined as a body mass index above 30. It's a risk factor for many conditions. Weight loss above 5 to 10% come for significant metabolic benefit, and this is something we really want to emphasize to our patient. And we have touched a little bit upon the use of diet, exercise, drug, surgery for the management of obesity. Thank you very much.